My name is Dr. Sadia Iqbal. I hope everyone is able to hear me clearly. So, today's session is regarding the history taking. Uh, Before going on towards the history taking, I would like to tell some informative things about the importance of history taking. In the history of medical career, it is very important to understand the techniques, the pros and cons, the micro and macro manipulations that are required, the tips and tricks that are required for the art of history taking. While we say that history taking is a part of basic part of medical sciences, but as far as the your career is concerned, even in the future, it is supposed to be an art. If you're able to take the history in a proper way, you are able to get that 70% of the diagnosis of your patient even without touching your patient. So if you're competent enough in your history taking, it means that you have got a hold on your 70% of your diagnosis. So history taking is basically a very structured type of a session. First, you need to introduce yourself and you need to explain to the patient that what are you going to do and how are you going to hear the patient out and how are you going to inquire the patient out. I think you're able to see my screen. I want to share a slide that shows 8 components of the structure session, comprising of the introduction, chief complaint, history of presenting illness, past medical history, systemic inquiry, family history, drug history, and social history. This is basically a very, very basic breakup of the components of an essential history taking. But the history taking is like modified according to the nature of the illness of the patient. For example, if you're taking a patient or history of a patient who is associated with some type of gynecological complaints, you need to especially focus on the puerperal history, the pregnancy history. If you're dealing with a history of a child, an infective illness, you need to you need to inquire about the immunization history, the birth history, the sequence events in the pregnancy that have been gone through by the mother and the child. So there are bits and pieces of every history that needs to be added upon. While you're dealing with a patient, you need to specify it according to the type of the patient you're dealing with. So coming towards the importance of the history taking, as I earlier mentioned, that a large percentage of the time, 70% approximately, is allocated if you are able to take a good history. Please remember, the basic parameters of history taking is that you don't need to be inquisitive to the patient. You do not need to be interrogative to the patient. Assalamu alaikum ji. I am back. This is Dr. Sadia Iqbal. I hope everyone is hearing me loud and clear. So
मैडम आपकी आवाज नहीं। जी मैम, स्टार्ट। हेलो,
Everyone, I am back, and I've been told that there is some issue in the internet connectivity from the OJA server, probably. And I've been waiting like with you guys since 30 minutes or 25 minutes. Let us go back to the chief complaint, but I would like to go through a quick review of our previous slide, taking the history and recording history. So always record the personal details. You need to know the name, age, sex, gender, ethnicity, occupation, religion, marital status, and date of examination. Please bear with me. I'm going to be a little bit quick now because we are getting short of time, and I've got type of a long lecture to give. So, why this is important? Because there are certain diseases that are prevalent in certain genders. There are certain pathologies that are prevalent in certain ethnicities. For example, familial Mediterranean fever is very prevalent in the Mediterranean region. For example, the Behçet disease is very common. It is a type of vasculitis, very common in the Turkish part of the world. So, the sexually transmitted diseases are mostly prevalent in the married couples, obviously, in our part of the world. So these are, not only apart from the fact that this is the biodata, which is the basic identity of the patient, it also helps and contribute towards getting a bit type of a clue towards certain diseases. So the history taking is broken into certain headings, which are the chief complaints, which should be a single liner, and it should include the duration from which the complaint has been present or has been existing, the period of time, that is. The history of presenting complaint is the elaboration of the chief complaint. The past medical and the surgical history, systemic review, family history, drug, blood, transfusion history, social history, and again, if you're dealing with a pregnant patient, you need to know the gynae and ops history of the patient. So we are not going to go into the gynae ops history. We are going to go through the very basic component, that is the chief complaint. The main reason which shook the patient to visit the hospital. You should be very, very relevant and specific while focusing on the chief complaint, because this chief complaint is going to give you your diagnosis. The patient is going to elaborate the chief complaint along with all the non-relevant and the relevant information as well, but it you need to be so much and so present in your mind, present in your senses, that you need to be able to filter out the relevant information. Please note, the chief complaint given by the patient might not be relevant, but you should focus on the relevant component. For example, chest pain, palpitations, shortness of breath, nausea, vomitings, abdominal pain. So these are the complaints which push the patient to visit the ER, to visit the OPD. So focus on these alarming features. Rest of the complaints that the patient is giving in, you need to be able to fit in with associations. Like, for example, the patient is having chest pain with nausea, the patient is having abdominal pain with nausea, the patient is having cough with shortness of breath, the patient is having fever with burning micturition. So you need to be very precise that what started first and how long it is there. This is your chief complaint. The duration is always tagged with the chief complaint. You cannot put up a chief complaint in the absence of duration. So after going through the chief complaint, you need to go through the history of the chief complaint. But the tips of dealing with the chief complaint is the exact duration, that is for how long you are ill, when you were completely normal. See, this is a very interesting and another way to ask the patient that since how long you have been sick. You can ask him that when you were completely normal. So You need to be very manipulative with your words. In this case, this complaint for the first time, or have you had any other episode? But please remember, you do not need to interrupt the patient. You do not need to be interrogative, in the interrogative mode with the patient. But let the patient finish. Let the patient speak himself, and in the end, you'll be having plenty of time to inquire what you specifically want to acquire. So, coming towards the history of dental illness, this domain describes the elaboration of the chief complaint. The elaboration comes in forms of associated symptoms. As I just mentioned, that a patient is coming to you with complaint of shortness of breath. You need to ask the history of fever, the history of cough, whether it is productive or not, the history of chest pain, the history of palpitations, because this shortness of breath can be cardiac as well, can be respiratory in nature as well. So you need to focus in the associations and the relevant features which are relevant to the presenting complaint, that is the chief complaint. So while the patient is describing his associations, start focusing on the differential diagnosis in your mind. Take points from the history and decide and weight what you're going to put in with the chief complaint and what things are you going to discard from the history which you think are not relevant. So HOPC is really very important because it forms the backbone of your history. So you should be very, very precise while dealing with the time of onset, mode of evolution of symptoms, any investigation that has been carried out, any previous hospital visits that have been done. If yes, what is the course of the disease? What is the nature of the disease? Has it been worsening over the period of time? Has it been improving in the period of time? Is it responsive to some treatment that is taken in the past? Is it not responsive to any treatment? So you need to describe it in the way a storyteller tells a story. You need to be very sequential, you need to be very organized, although the patient might not be that much organized while telling you the history, but while you're dealing with your history, you need to organize it in your mind. So uh, this is a very heavy slide, but I'm going to read it out for you. If the patient has more than one symptom, like chest pain, so it becomes a bit complicated over here. Chest pain, swelling legs, and vomiting. Take each symptom individually and follow it to fully mentioning the significant negatives as well. For example, the pain was central, crushing pain, radiating to the left jaw while moving the lawn. It lasted for less than 5 minutes and was relieved by taking rest. So this this point, this clue in the history is classical, very, very, typical of a cardiac pathology going on, because the chest pain is happening in the presence of exertion. And when the exertion is gone, the chest pain is gone. So this chest pain is relevant to a cardiac pathology, not a respiratory pathology, not a musculoskeletal pathology, not a bone trauma, not a bone fracture. So if it was the case, that is in case of any trauma, it should have been present all the time, even in rest and even at rest and even at manipulation, any manipulation being going on. So uh, another tip is that you need to avoid the medical terminology and make use of the descriptive language that is familiar to the patient. You're not going to ask the patient that since how long you have been having GERD. You're going to ask the patient that since how long you're having this epigastric burning. So this is a very basic way of getting not only with familiar with the language of the patient, but also it is going to polish your skills, that how a layman terminology or a number of layman terminologies can be transformed or interpreted by a medical personnel into scientific knowledge that is relevant and that is required for making a clinical diagnosis. So While dealing with the history of presenting illness, that is the HOPC, you need to ask the OPQRSTA. This is a small mnemonic, but it is very, very important because it designates the onset of the disease, the position and the site of the pain, the quality and nature of the pain. There are different modes of pain like burning, stabbing, crushing, superficial pain, deep pain. The patient is going to tell you everything. So there is relationship of pain with any other association. For example, the patient's pain aggravates while moving, the patient's pain release while settling down, or there are some type of pains that are relieved while activity. For example, the pain of all the rheumatological diseases, inflammatory diseases, especially the inflammatory joint diseases like rheumatoid arthritis, they show dramatic improvement with activity. So you need to evaluate the relationship of your complaint. You need to know the radiation of the complaint, the pain that is, if there is any epigastric pain, is it radiating to the right hypochondrium, is it radiating to the left hypochondrium, it is radiating to the back, because every radiation is relevant to every organ, and that is going to give a clue towards your diagnosis. You need to classify the the severity, mild, moderate, or severe. There is no particular scale, but you need to be able to evaluate it in terms of activities of daily living and carrying out the physical activities like sleep, walk, or exercise or yoga. So I was telling you about the relevant history. The past history of the patient is really very important, because a patient of chest pain is giving you history of previous coronary artery disease, angioplasty. It becomes very significant. There are certain diseases that are, socioeconomically labeled. For example, tuberculosis. So if a patient has or a family member has a previous history of tuberculosis, it becomes relevant. If a patient has a history of epilepsy in the family and has presented to you with fits for the first time, there is a genetic tendency of epilepsy as well. So it becomes relevant. So you need to focus on the past history of the patient and the family as well while making and elaborating your history. Past surgical history again is really very important. The time, place, and what type of operation was done, what blood grouping was done, and was there any need of blood transfusions, history of dental extractions, history of any GI procedures, history of any traumas. So now, after dealing with the previous, blood transfusions, hospitalizations, and medical illnesses, the next important domain is the drug history of the patient. The drug history, you should be very specific. You should be aware of the generics. You should also be aware of the brand names, because a lot of patients are not that much educated that they are going to give a specific piece of information to you. So you should be well aware of the generic and the trade names, the brand names, the market names with which the patient is being prescribed, the drug's duration that he has been taking along. And you also need to inquire in particular about the over the counter medications, any ayurvedic medications, because they have a lot more of association with the symptoms, or can have a lot more of association with the symptoms. Other than that, you need to be aware of the medical terminologies that are related to the prescription. BD stands for twice daily, that is morning and night. TDS stands for thrice daily, that is after every 8 hour, morning, evening, and night. QDS stands for four times daily, that is every 6 hour. OM is the morning, symbol. The ON is the nocti, which is the night symbol. AC is before food. PC is after food. Per oral is by mouth. Stat or statum is means that there is only one dose that is to be given as the initial dose, and you do not need to carry it out any further. The RX symbol is the treatment symbol, and this is the heading with which the treatment is prescribed. Not almost always, because I think these are German Roman symbolizations, but yes, BD and TDS, QDS, and stat per oral. These are very familiar terms, and when you're going to enter in your the ward postings, you will be very familiar with it while looking towards the file of the patient, because we practice it very commonly. So any familial disease which has a genetic base running in the family, like breast CA, ischemic heart disease, diabetes mellitus, schizophrenia, developmental delay, asthma, albinism. I'm pretty sure that most of you are not very familiar, but with the name of the diseases. But the important thing here is not to understand the disease, but to understand the fact that not only the person who is coming to you with a complaint is important, but the family background is really very important as well. As I just mentioned, that for example, in our part of the world, in the third world country, that is Pakistan, where people are living in very close spaces, no adequate ventilation in houses, a person infected with TB is very, very much able to transfer the germs to the people living in his surroundings. So certain diseases are genetic based, having their predisposition on the basis of genetics. Certain diseases have their predisposition on the basis of the socioeconomic status, like tuberculosis, like leprosy. Like certain diseases are associated with hygienic conditions, like cholera and typhoid. So the family history, the social background is important in that context, that it is going to give you a clue towards the diagnosis as well. Social history. Um, Social history is, I would like to say that social history should never be missed. Should never be missed. The social history includes the smoking history, the alcoholism history, the appetite, the sleep, the bowel habits, the occupation, the educational background, the activities of daily living, the family support system, social economic class, and home conditions, like how many houses are there, how many windows are in your houses, is there adequate ventilation or not, is the every room is provided with a fan or not, what is the type of water that is being used by the family member, is it tap water, is it mineral water, is it boiled water. Like, this is really very important for the cholera, this is very important for the viral gastroenteritis, this is very important for enteric fever. It is such a devastating disease. We are having an XDR, the extreme drug resistant enteric fever in our part of the world. So water and sanitation condition, pets, somebody who is allergic, somebody who is asthmatic, having pets at their home, this is a triggering factor. It is going to give you a clue towards your diagnosis. So the social history in terms of smoking, alcoholism, occupation, activities of daily living, financial support system, socioeconomic class, sanitation and hygiene maintained by the family members, type of the water used, are there any pets in home. These individual points are going to give you clue towards your diagnosis. So let's elaborate it. The most important cause of preventable disease, smoking, should be evaluated in terms of its amount, duration, and type. By amount, I mean to say number of cigarettes per day or number of pack per day. You need to evaluate the pack per year calculation as well. There is a particular formula which will be told upon when you will be dealing with your wards, hopefully. And then the duration, any trials of quitting, any motivation, is the patient feeling motivated enough to quit or not, and the effects of breathing, the number of family members that are smoking at the moment. So, smoking come in different forms like, vapors, e-cigarettes, cigars, packs, shisha. These are all types of smoking. And by the way, the Packer calculation and the passive smoker inquiry is really very important, because the Packer calculation is going to give you a clue towards the time of exposure that the patient has elapsed since the onset of the damage that has been caused by the smoking, because we all know that smoking is a very big risk factor for bronchogenic carcinoma. Apart from that, the passive smoker, the person who is not smoking but is exposed to smoke fumes, is almost at the same amount of risk as that of an individual who is actively smoking. So you need to be aware that either your patient, if not an active smoker, is he a candidate, is he a victim of passive smoking or not. So coming towards the final points, that is, if you have time, if the patient is willing, is showing interest, you can ask about whether he's willing to quit, how many efforts he has done to quit, and how are you going to help him if the patient is willing. Alcoholism is, there are number of diseases, that is, the most important of which is very very prevalent in our part of the world now, is the alcoholic liver disease, alcoholic cirrhosis. And you need to evaluate about the type of the alcohol, the amount of the alcohol, whether it is falling into the safe range or not. That is, men should be not greater than 4 units per session or not. Females should not be advised to take greater than 2 units per session. This is very scientific, but you need to inquire about the alcoholism history. Apart from the liver disease, the alcoholism is associated with cardiomyopathy, cerebrovascular accidents, peripheral nervous system dysfunctioning, peripheral neuropathies, and myopathies as well. So, coming towards the other relevant history, that is the gynae and the obs history, you should, or you can inquire about the gravidity, the number of times the patient has conceived, parity, the number of times the patient has been pregnant, abortions, the number of times the patient has lost a child, and cesarean sections, antenatal care, screening for Hep B and C. Other relevant history includes immunization history, whether the child has been immunized. If you're dealing with a patient who is, around 12 to 14 years of age and coming to you with a type of problem that you need to really focus upon, the immunization history. The travel history, sexual history, again related to sexually transmitted disease, patient having penile, vulval, vaginal problems, you need to inquire the sexual history, the marital status, it becomes very significant. So, please, I just want to focus upon a point that while inquiring with the history of alcoholism, smoking, and the history of sexually transmitted disease, you need to be very very decent in terms of your questions, so that you don't make the patient feel offended. And apart from that, at the same time, you should be able to inquire the relevant piece of information in a very decent manner. And if the patient denies, if the patient refuses, let it be, because it is the right of the patient. So every time when you go through a personal question that is very personal to the patient, you need to be very decent in your language and less intimidative, I would rather say. So now comes the most difficult part, which is the systemic review. Now, this is the part which is going to cover every organ system of the body and its relevant complaint. Whatever you have missed in your history is going to get caught in this part of the history. Some people emphasize on systemic review on so much and so that they prefer to take the systemic review just immediately after the history of presenting complaints, because they consider that it is going to contribute significantly in the diagnosis. So they prefer to take it just after the evaluation of the history of presenting complaint, while some people prefer it to inquire it at the end of the session, so that if anything is missed in the history, it can easily get caught in the systemic review. So, the method of taking systemic review is very scientific and very organized. First, you need to inquire about the general complaints, that is, weakness, fatigue, anorexia, fever, chills, lumps, night sweats, change of weight, gain of weight, or loss of weight. These are the general, very basic questions that are inquired while at the beginning of the systemic review. Coming towards each and every system, you need to memorize it, because this is the core part of the history taking. Nothing gets missed if the systemic review is taken in this manner. In the cardiovascular system, you should inquire about the chest pain, paroxysmal nocturnal dyspnea or topnia, shortness of breath, productive or dry cough, swelling of the ankles, palpitations, and cyanosis. In the GI, the alimentary system, you need to inquire about the appetite, diet, nausea, vomiting, difficulty in swallowing, epigastric burning, heart burning, bloating, flatulence, regurgitation, hematemesis, melena, hematochezia. Hematochezia is the per-rectal bleed. Melena is the coming of dark, tarry, black-colored offensive stools indicative of the upper GI bleed, and hematemesis is the coming of the coffee ground vomitus from the upper GI tract, and jaundice. Things to be inquired include blackouts, loss of consciousness, any abnormal sensations, tremor, paresthesias, paresis, or any type of neurological deficits, including all types of loss of sensations like smell, taste, hearing, speech, and visual problems that comes under the domain of the neurology. So, the genital system. Systemic review includes pain and discomfort and itching in the genital area, any discharge, unusual bleeding, history of promiscuity, sexual history, menstrual history, and obstetrical history. In the menstrual history, you need to be very specific about the menarche, the onset of the menstrual cycle, the last menstrual period, duration and amount of the cycle, and any type of contraception that is being used currently or has been used in the past by the patient. The musculoskeletal system should be dealt in a way that includes the pain, muscle, bone, and joint. All three domains should be elaborated in detail. Swelling, weakness, movements, deformities, and gait disturbances. By the way, it should be remembered that gait disturbance can fall under the domain of neurology as well as in the musculoskeletal system, because the gait is controlled by the central nervous system. But if the patient is having any difficulty in any part of the joint that is involved with walking, the gait is going to be eventually compromised. So you need to be vigilant while dealing with the issues in gait. So this is the not very relevant to you, because this is the SOAP format, and this format is used by the HOIS officers and by the postgraduate. But because it is a very effective format of dealing and organizing the plan and the assessment, I'm going to share it with you people. The subjective, objective assessment and plan, this is called the SOAP analysis. Subjective is what the patient going to tell you. What are the presenting complaints? What is the condition that has been suffered by the patient? How is the patient looking? The objective component is the part that is being observed by you. including the vital signs, the journal physical condition, the temperature, the input, the intake, the urinary output, the quantity and the amount of the stool pass, the laboratory investigations, and its interpretation. So, subjective is what the patient is going to tell you. Objective is going to be your concrete analysis in terms of your patient examination, in terms of patient's vital signs, and in terms of laboratory investigations. After dealing with both of them, you're going to make an assessment. You're going to address each and every problem individually by making a problem list. See, this is a very effective way of dealing with the problems, and it becomes effective in such a way that every problem contributes or contributing towards a particular diagnosis can be dealt very effectively and nothing is missed while making the differential diagnosis. The plan is the end part of the SOAP analysis, and in this part you're going to go for your management, go for your treatment, you're going to organize your further investigations, you're going to organize your further follow-up, and you're going to discuss the rehabilitation of the patient with your colleague, with your patient. So this is a very basic and a comprehensive way of elaborating the detailed patient history, examination, your assessment, and your plan so that you become the treating physician in the driving seat. So I think this was all about it. And if anyone wants to ask any questions, I'll be happy to answer.
लगता है मैम सब सो गए। हेलो मैम, आवाज आ रही है आपको? नोटिस आ दिया?